fantastic. I've seen the organization grow over the years, and our conference, I think, it now reflects the growing interest and development in the area of scientific knowledge and academic programs in the area of addiction studies. So it's my pleasure to be here today and to welcome everyone to the Symposium 3, Innovative Interventions in Substance Use Treatment. So I want to welcome you again. We're fortunate to have 4 very distinguished presenters this morning from all over the world, Pakistan, Nigeria, Vietnam, and Ukraine. I think there's no better way, in my opinion, as a licensed clinical psychologist, to start the conference than by discussing innovative strategies related to substance use treatment. So let me first introduce the presenters, and we hope to have some time for questions at the end of the session. So I will apologize in advance. We have very brief sessions, very brief presentations, as we'll have in most of the symposia today. We'll start out with Dr. Charles Nwoga, sitting here to my right. And the co-presenter, who's not here, I don't believe, is Professor Moses Audu from University of Jos. He'll be talking about assist-linked multi-session brief interventions for substance use in Nafok community of Plateau State. And I will briefly just share information about each of the presenters. Dr. Nwoga is from University of Nigeria, and he has spent 9 years as a consultant psychiatrist with Jos University Teaching Hospital. He's also a global trainer for UNODC and has done considerable amount of training, has a lot of expertise in treatment and rehabilitation, and we look forward to his presentation today as our inaugural speaker for the session. Our second speaker will be Dr. Jawwad from Pakistan, and he will be presenting today on effects of musical therapy during treatment of drug-induced psychosis. And I'll just briefly present Dr. Shujaat's credentials. He's an assistant professor of psychology with an additional role as vice principal in a public sector college in Punjab, Pakistan. He holds a PhD in clinical psychology, is also a national trainer for UNODC, and for Colombo Plan, the DAP program. He's a global trainer for DAP, also is a director of the AZM Addiction and Psychological Treatment Center. So we look forward to his presentation as well. Third, we have Dr. Chum Chan, who is Deputy Director of the Department of Science and Technology at Haiphong Union of Science and Technology Associations in Vietnam. She's co-presenting with Dr. Khary Rigg, who is not here, but is from my university, University of South Florida. She'll be presenting this morning on methadone maintenance with women in Vietnam. I'd like to briefly present her bio information as well. Dr. Chan was a 2017-2018 Humphrey Fellow at Virginia Commonwealth University, very prestigious fellowship. She holds a PhD in behavioral and community science from the University of South Florida in Tampa, Florida in the US. Just one of our recent graduates from the program. Fantastic, and I had a chance to work with her for several years during her stay at the PhD program. Dr. Chum is also a UNODC Global Drug Demand Reduction Trainer as well. So we have a common theme here of connections with UNODC and international work as well. So we want to welcome Dr. Chen. Finally, we have Dr. Alla who's with us today from Ukraine. She's a psychologist at NGO DolaDu, and also an expert with the Council of Europe. She'll be talking today about psychoactive substances prevention among militaries The Price of Independence in the 21st Century. So really looking forward to some very exciting presentations. I'll briefly describe her background as well, trying to move as quickly as I can so we can get time for the presentations. Dr. Shujaat is a psychologist in the Ministry of Interior of Ukraine. Although she's living in Spain at the present time, she simultaneously completed a program in medical psychology. She has developed guidelines for, has been working with the Council of Europe projects since the war in Ukraine started in 2022, and also has developed guidelines for prison staff, what you should know about people with substance use disorders, and ran the opioid substitution treatment program in prison and also in pretrial facilities in Ukraine. She became a national trainer of the Ukraine International Technology Transfer Center, Technology Center, ITTC, and is now working again, as I mentioned, with the NGO DolaDu to support militaries and provide them with psychological support, as well as to share information about substance use disorders and treatment. Very good. And I want to welcome all of the presenters. And again, we're going to start this morning with Dr. Charles Nwoga. Thank you very much.
Good morning. Today, I'm going to speak on our work. We looked at the feasibility of using assist-linked brief intervention for substance use disorder in a rural community in Plateau State in Nigeria. Nigeria is a large country with a population of about 220 million, and Plateau State has a population of about 4.7 million. So we know generally that substance use is a global problem, but particularly in our state, Plateau State, where we are, we've been on the news for a lot of crises. We started with the ethno-religious crisis in 2001 that graduated to the Boko Haram crisis, and since then, there's been a lot of rise in substance use disorder. And it has posed a lot of problems to both currently and even to the future life of the individuals in the state. The UNODC World estimate for substance use disorder in the global population is about 5.6%. That was in 2016, and 5.5% in 2019. But particularly in Nigeria, it was estimated that in 2018, we had a global average of 5.6. We had a national average of 5.6, which is higher than the global average of 2016. And what was also found in that UNODC survey in Nigeria in 2018 was that poly drug use was very, very common. And majority of the drug users were dependent. And there is a clear gap in meeting the needs for treatment for these people that are dependent on drug in Nigeria. About 40% of the population that is dependent on drugs in Nigeria cannot access treatment. Not that they don't want, but because in Nigeria, treatment is not free. Payment is out of pocket, and the income level is very low. The employment level is very low, and the majority of the population are living below the poverty line. So the barriers that prevent people from accessing treatment, the cost of treatment is very high, and then there's stigma associated with accessing such services. Most of the treatment centers are standalone treatment centers. So people fear walking in there to access treatment because they'll be looked at they are not mentally well. And then there's also stigma associated with substance use in the community. There, people tend to disown them, family tend to abandon them, and they look at them as people that will not amount to anything again. And then, even where people want to get treated, the availability of treatment is not there. Then there's a lack of understanding of even the concept of substance use disorder in Nigeria. Particularly from the cultural perspective, people first view it as a spiritual problem. then they will now view it as a religious problem. So their pattern of presentation is that they will first go to the spiritualist who will cleanse them. From there, they get to the church, and then they end up in the hospital at a stage that they are already dependent. So you get them at a very late stage. So what happened was that we had to use the World Health Organization alcohol, smoking, and substance involvement screening test as 6-link brief intervention to look at how we can help such individuals in the community. And this is based on the brief intervention protocol, the FRAMES protocol of feedback, responsibility, advice, and menu of options that you can provide to people with substance use disorder. And a lot of research evidence has shown that if you give a multi-session brief intervention to individuals, ranging from 30 to 90 minutes intervention, it helps in reducing the drug use among them. Why did we try to do this study? This community that we looked at in Plateau State is a small community. Many of the youths, young men there, women, were getting into drug because they were involved in ethno-religious crisis, and they were losing interest in other forms of employment, losing interest in education. Even those ones that were in school were gradually dropping out of school. And then majority were interested in getting help, but they could not afford the help. The treatment centers that was closest to them was over 100 kilometers away. And even the cost of treatment was above the reach of the common member of the community. So there was an NGO that identified this community and was looking for professionals that could help to intervene. And that's where our organization came in. So we went in with this WHO assist-link brief intervention. What we did was we did a cross-sectional study using the convenience sampling method. And we sampled those that were 18 years and above. And then we excluded those that already had a diagnosis of mental illness prior to the onset of their substance use. We also excluded those that are already receiving treatment for substance use disorder. And we excluded those that refused to participate. So what we did was we used the community gatekeepers to get individuals that are involved in substance use, and then we addressed them, gave them psychoeducation, introduced the concept of the study, and those that were interested gave their consent, and we went on. So we screened them with a brief assist, and then we provided brief intervention and motivational interview in multiple sessions. We did 12 sessions over 6 weeks, and the data was analyzed using SPSS. What we found was that there was a significant mean difference between when we did the study and at the end of the study. We also found out that the majority of the participants were within the age range of 21 to 30 years, and this is the productive age group in the society. So you find out that the economic activity in the area was drastically being affected, and there was need for intervention. And then we found out from the study after the analysis that the prevalence of nicotine use was 72%, alcohol was 66.7%, cannabis was also high, and the rest. And more than half of the participants have tried severally to quit their drug use habits, but they could not succeed on their goal. And the assist course was mostly at the severe ranges. Yes, this was very important because usually brief intervention is said to be more effective when it's offered to people with mild or moderate assist course. But we had to try it for those with severe scores to see if it can bring a change among them. And then we looked at the results that we got. We found out that there was a significant effect size between the assist score at the beginning and then assist score after 12 weeks of multiple session brief intervention. And the effect size was high for tobacco, it was also high for opioids, it was high for alcohol and cannabis. And then we also find out that if we use the COSD guidelines to interpret it, we find out that it's possible that this assist sleep brief intervention will be a good method to use when other methods are not available to reach people that have substance use disorder, even at the dependence stage. Thank you.
Save the questions for the end of the session. We'll move now to Dr. Jawwad.
And all the respected participants and the persons who are working in the field of addiction, whether they are working in prevention or in the treatment sector. My topic is effects of music therapy in management of persons with drug-induced psychosis. Here is the outline of my presentation. Abstract, the main objective of the study was to investigate the comparative effect of pharmacotherapy and music therapy on psychiatric symptoms and global assessment of functioning among patients with drug-induced psychosis. True experimental design was used in this research. A sample size of 150 patients with drug-induced psychosis were selected to given treatment by using purposive sampling technique. Two groups were formed. Group 1 received only pharmacotherapy, whereas Group 2 received music therapy along with pharmacotherapy. It was found that patients of Group 2 exhibited better results on global assessment of functioning, and patients also scored less on psychiatric symptoms. Study has implications in the field of drug addiction rehabilitation and mental settings. Mostly, drug-induced psychosis is a condition which is due to the effect of excessive use of drugs, and it is a severe mental disorder in which client may feel hallucination, delusions, and he lost his contact with reality. And the use of music is very old technique in treating the mental disorders. The use of music in therapy is not a new concept. It has been used as a therapeutic tool for centuries to promote physical, emotional, and psychological well-being. In recent years, the use of music therapy has gained popularity in the treatment of various mental disorders, including drug-induced psychosis. Music therapy involves the use of music as a means of communication and expression to promote emotional and psychological healing. As I am from Pakistan, and Pakistan is a Muslim country where most of the extremist groups are not allowing to use music. And it is really a challenging task to use such techniques. Even there is some moderate persons who are using some musical devices as known Qawwali. They use these techniques to relax the people in common society. Objectives to investigate the comparative effects of pharmacotherapy and music therapy on psychiatric symptoms and global assessment of functioning among patients with drug-induced psychosis. To investigate the comparative effect of pharmacotherapy and music therapy on psychiatric symptoms and global assessment of functioning among patients with drug-induced psychosis. Research methodology, the design of the current study was through experiment pre and post design. A pre-test, post-test design is an experimental in which measurements are taken on individuals both before and after they are involved in some treatment. Pre-test, post-test designs can be used in both experimental and quasi-experimental research and may or may not include control group. Research area, the study will be conducted in Rehabilitation of Center of Sargodha, Punjab, province of Pakistan. Pakistan is an Islamic country officially known as Islamic Republic of Pakistan, a country in South Asia. It has world's second largest Muslim population. Pakistan is the 33rd largest country by area. It has a coastline along with Arabian Sea and Gulf of Oman and is bordered by India, Afghanistan, Iran, and China. Sample research target population included patients with drug-induced psychosis. Purposive sampling approach was used. The current research sample size was 150 patients. As in Pakistan nowadays, the use of ice, amphetamines are increasing day by day. And that is producing drug-induced psychosis in most of the clients which are reported for treatment. Subject criteria, inclusion criteria, the sample includes male patients with a documented diagnosis of drug-induced psychosis between the ages of 30 and 45. Only married individuals were enrolled. And the selection of male clients is due to the cultural and religious boundaries and restrictions. In our society, there is still, people are not accepting that their females of our society are using, but they are using in a huge quantity and they prefer to treat them at home, or they try to go to some shrine or some kind of religious scholar to do some religious words for treatment of that girl. Exclusion criteria, patients who were single, divorced, widowed, separated, or had a concomitant medical condition were not included in the sample. Additionally, patients who were unable to understand Urdu were also cut down from the sample. Those who could readily understand Urdu were more likely to follow the researcher's direction. Tools, the global assessment of functioning and brief psychiatric rating scales were used. The global assessment of functioning revised scale to determine the severity of mental disorders. Pedersen created the global assessment of functioning on a scale of 0 to 100. It gauges how much a person's symptoms interfere with their normal life functioning. And all the drug-induced psychotic patients are not working in the society properly. Brief psychiatric rating scales by Zinello, a brief psychiatric assessment scale was established. People who have schizophrenia or another psychiatric condition or who are suspected of having it exhibit the disorder in a variety of ways. 8 symptoms constructs including aggression, suspiciousness, hallucination, and grandiosity are evaluated by the BPRS. Before starting the study, the Rehabilitation Ethics Committee provided its permission for its ethical conduct. A signed informed consent was required of both the experimental group and control group participants. They received information about the research and how to resign from it at any moment without suffering consequences. The experimental group was required to use a smartphone to access their own personal music library on a personal computer. To provide the clients with instructions, one volunteer was recruited who was neither a member of the hospital staff nor a direct participant in the study. The volunteer instructed the patients to search for their preferred music on YouTube or follow voice commands to listen to their own music. They were also instructed to listen to music while clearing their mind of all ideas in order to experience the omnipresence of God. That is due to the religious effect and impact in our society. So it's important to use this technique. All recreational activities other than listening to music were required of the control group. Pre and post assessments were completed using BPRS and GAF at the pre and post level. The treatment group participated in 56 sessions with 45 minutes structured group sessions twice daily for 4 weeks. Statistical analysis were carried out through SPSS 25 variant. There is the table 1. Table 1 description, the above table shows the impact of pharmacotherapy on psychiatric symptoms. Results indicated significant mean differences across 3 conditions in group 1 and group 2. Participants of group 2 who received both pharmacotherapy and music therapy were exhibited better results on psychiatric symptoms as compared to participants who only received pharmacotherapy. Here is the graphical presentation, difference in group 1 and group 2 on the basis of intervention psychiatric symptoms, and the group 2 is performed better. Figure 1 shows differences between group 1 and group 2 based on type of intervention and their impacts on psychiatric symptoms. It is shown that the combined effect of pharmacotherapy and music therapy was more effective in reducing psychiatric symptoms as compared to only use of pharmacotherapy among patients. Table 2, impact of pharmacotherapy and music therapy on global assessment of functioning. This table is also clearly shown that the clients who were used pharmacotherapy along with music therapy exhibited better results and show more higher results on global functioning of assessment. Figure 2, differences in group 1 and group 2 on the basis of intervention on global assessment of functioning. Figure 2 shows differences between group 1 and group 2 based on type of interventions and their impacts on global assessment of functioning. It is shown that the combined effect of pharmacotherapy and music therapy was more effective in increasing patient score on global assessment of functioning as compared to only use of pharmacotherapy among patients. The patients who were received only pharmacotherapy reached 71 mean score on global assessment of functioning, while the clients who are receiving both music therapy and along with pharmacotherapy reached the level of 91 mean score on global assessment of functioning. Findings of the study revealed that music therapy along with pharmacotherapy was more effective in decreasing patient score on psychiatric symptoms as compared to only use of pharmacotherapy among patients with drug-induced psychosis. Previous studies also support the findings of the current study that music therapy along with pharmacotherapy is more effective as compared to use of pharmacotherapy alone in reducing psychiatric complications among patients. And the discussion is also that innovative approaches are also giving better results in all the psychiatric patients, but the challenge is that cultural and religious restrictions are restricted the professionals to work for the betterment of such clients. Conclusion, it was found that those patients who were treated with a combination of pharmaco and music therapy exhibited less psychiatric symptoms and scored higher on global assessment of functioning as compared to those patients who were only treated with pharmacotherapy. The findings of the current study could also be discussed in the context of the patient-centered perspective by focusing on 2 key issues: the potential contribution of music therapy to more comprehensive care that is in line with the patient-centered.
Good morning, everyone. My name is Cham Chan from Vietnam, and today is my pleasure to share one study that I conducted with Dr. Rigg from University of South Florida. My study is entitled Methadone Maintenance with a Woman in Vietnam. And just an overview of my presentation today, I provide an introduction, methods, result, and discussion. So I would like to provide a brief introduction to the study. As you all know, that opioid misuse is a global issue, and without 10 years, the number of people who misuse opioids double from 31 to 60 million. And the number of people misuse opioids and have opioid overdose deaths are rising in so many countries. And one of the countries that have very high rate of opioid misuse is Vietnam. It is estimated that among people who misuse drugs, 85% misuse opioids. And this results in many multi or long-lasting consequences, including the HIV pandemic in Vietnam, HCV, overdose deaths, and treatment admissions. When it comes to treatment for opioid misuse, methadone has been proven to be a safe and effective treatment, and it's a long-acting synthetic and full analgesic, and as long as it's used as prescribed, it's safe and very effective. And despite the fact that methadone became available in the US since 1970s, in 2008, in Vietnam, we started piloting methadone treatment in 6 methadone clinics. And so far, we have methadone treatment in all provinces and cities in Vietnam, serving around 51,000 patients. And so why we conduct this study, understand the context of methadone treatment in Vietnam. We were amazed and surprised by the very small number of women in methadone treatment. And earlier last year, we conducted a systematic review among methadone patients. And just a side note, if you have time, please visit the poster section, and I will provide more information about that systematic review. However, when we screen all the studies that conducted among methadone patients, we were amazed because the number of the women was just account for 1.9% of the whole sample. So among over 6,000 methadone patients in those studies that we include in the systematic review, only 1.9 were women. And for example, in my hometown, Haiphong City, we are serving for 3,900 patients in total, but only 76 are women. So when we screen through all of these studies, we were looking for the information related to women, like why there was so few women participate in the treatment, and we found out that they neither did not mention why, or they provide some information like because we could not recruit women in those studies. So we were wondering, was that because we don't have any more patients, women who use opioid out there that actually need treatment, or is there any reason that they didn't come to treatment? So this was when this study came into play. And you all know that there are it's proven that there are gender differences and sex differences when it comes to substance use pattern, right? For example, when we talk about sex differences, it's biological differences. Like, for example, women, they tend to metabolize nicotine faster than men. But when it comes to alcohol, men tend to metabolize alcohol faster than women, or any other reason that maybe hinder women come to treatment. So it trigger our curiosity, and we want to look at that. So this is why we think that our study is innovative, because this is the first study that actually look at gender approach when it comes to methadone treatment. So, or maybe we need some intervention that better fit with women so that they can come to treatment, right? So our research question include, are there any gender differences in substance use pattern? Any difference among men and women regarding reasons for them to come to treatment, enroll treatment, right? And what about the attitude toward methadone treatment? Are there any differences? And talking about methodology, we collect data in 2 months in 2022 in Haiphong City. In 10 methadone clinics, we, because it's after COVID time, so we did an online survey to Quartic, and we used the question adapted from the National Survey on Drug Use and Health from the US, and the attitude towards methadone scale, and they received $5 in cash, and we conducted the percentage means and chi-square in using SPSS. And after giving the flyers and obtaining their consent, we invited them to screening for inclusion and exclusion criteria. So any patients that are receiving currently active in methadone treatment for more than 30 days and over 80 years old will be eligible for the study. So eventually we had 199 participants participate in the study, and we analyzed the data. So this table is maybe too small for you to see. So I would like to provide a very brief summary of this sample. The total sample consists of 199 participants with 141 men and 58 women. As I just said, in the whole city, we only have 76 women patients, right? So we try our best to get as many as women in treatment as we could. And the majority of them were from 39 to 59 years old. And regarding to education, only a third report completing high school, and more than a half were employed at least part-time, and 37% reported unemployed. Result, first of all, when we look at substance use, this table you can see that there are some differences between men and women. So overall, men and women generally use the same types of substance, and tobacco and heroin were the most prevalent across the sample. And we found there are two important gender differences in substance use pattern. First of all, you can see the highlight in yellow highlight part. That the first difference is the number of substances men and women use. Men were more likely to use 2 or more substances, and women were more likely to use 1 substance. And the second difference is the rate of alcohol use. Men were more likely to report alcohol use than women. About 68.5 men report using alcohol, and only 24.1 women report using alcohol. So this is quite surprising for us because we only found 2 gender differences when it comes to substance use. Regarding reasons for entering treatment, out of 16 items, we only found 2 items that show gender differences. Overall, findings show that men and women enter treatment for very similar reasons, and as you can see here, 4 items that received most endorsement from both men and women was getting into treatment was easy, I want to stop using drugs, my family wants me to do this, and I want to feel good about myself. So those are the items that received the strongest endorsements among both men and women. But we found that there are 2 items that show gender differences. I want to please someone, so men receive more endorsement from men, so men were like more likely to report that they want to enter treatment to please someone, and women are concerned about their health, so the reason they said I'm worried about my health was more strongly endorsed by women. So these are only the 2 gender differences that we found. When it comes to attitude toward methadone treatment, it was quite surprising that out of 26 items, only 3 of them show gender differences too. So overall, attitude towards methadone treatment was generally positive among both men and women, with a quite good mean score among these two groups. And the items that received a strong endorsement were: methadone allows addicts to lead a normal life, methadone takes away the craving for heroin, methadone has proven to be the best way of quitting heroin, and the difference when it comes to the items that show the gender differences was the item: the methadone can root your bones. The sooner a person stops taking methadone, the better. And methadone has been used more to stop crime than to help addict. And in those items, those are the reverse items, and they receive stronger endorsement among women. So this is kind of a question mark, why, right? But it's also very surprising that only 3 items show gender differences, and other items, they are comparable. Discussion. So for future practice regarding the substance use pattern, because the findings show that men are more likely to engage in polydrug use. They use more or 2 or more drugs. And so this suggests that men are at higher risk for overdose and poor treatment outcomes. Therefore, screening and assessment at clinics should be conducted with this in mind. And the finding also reported that men are at a higher rate of alcohol consumption. Therefore, more attention should be drawn to providing the alcohol-related interventions to men, as they appear to be at a higher risk of alcohol-related problems. Second, for treatment entry, the findings well reflect that the fact that methadone is accessible in Vietnam. We saw that patients have very strong endorsement that getting into treatment was easy for them, both men and women, right? So the intervention that so we can be very proud to say that maybe Vietnam is doing really well when it comes to implementation of methadone treatment in Vietnam. And given the role of the family in treatment in Vietnam, intervention that involve family, such as a craft intervention or ongoing interventions with psychological services like motivational interview, motivational enhancement therapy, and group work should be considered. Also, for attitude toward methadone treatment, we saw that there was some question mark about women, how they perceive methadone treatment. It's not necessarily that they have negative attitude toward methadone treatment, because the mean score show that they're still positive overall, right? But maybe we should pay more attention in raising awareness about methadone among women, because maybe there is some confusion there. Maybe they think that the methadone treatment is good, but still I don't fully understand how it works. And maybe I think that it's still bad in some way, but not clear how, right? So providing more education and raising awareness is very important. And for future research, it was surprising that we couldn't find many gender differences when it comes to substance use pattern, when it comes to reason for another treatment, and attitude toward methadone treatments. So we couldn't really explain what we were looking for. So I think that this study suggests future research to have a closer look and a deeper understanding what were the problems that hinder women coming to treatment. So if it's not substance use pattern, if it's not the reason for another treatment, if it's not about the attitude towards methadone treatment, so what are the reasons, right? So I think there's a need to conduct more quality studies to understanding, put them in the context, the result of this study in the context, and for them to describe and have a saying and explain why they think that there's still other issues that hinder them from coming treatment. And also from doing that, we can inform the providers with effective strategies for improving treatment utilization among methadone patients, especially among women. So that's all I had, and questions are welcome later on. Thank you.
Thank you very much, Dr. Chan. And our final presenter today is Dr. Alla from Ukraine. We'll be talking about psychoactive substances prevention among the military.
Hello everyone. I'm very grateful for my seat in Jawwad for having this opportunity to participate in this conference. And it's a great honor for me and my team in DolaDu that deals with mental health care to present our work, Psychoactive Substances Prevention Among Military, the Price of Independence in the 21st Century. This slide shows the scope and depth of our Ukraine problem. After more than 500 days of full-scale invasion, 9 years of major war, we have approximately 14 million of Ukrainians that need immediate psychological help. 10 million of Ukrainians are under the risk of psychological disorders caused by war, and near 51% of militaries need immediate specialized psychological help. Ukrainian military belongs to special category that includes civilians that joined Ukrainian army without any professional and military skills, just to protect their families and their territories from Russian aggression. So it means that today we have approximately 1 million of military and 1.2 military of veterans that need our help, and 5 million veterans will need our help by the end of the war. It means that approximately 12 million of military and military families and veterans are expected and need our help, and we now have a really lack of specialists and lack of institutions that provide such support. As it was said, I'm working in the NGO DolaDu, and a couple words about this organization that provides psychological support to individuals affected by war. We make the strong stronger. This organization corresponds to the strategic priorities of the country within the framework of the National Program of Mental Health and psychosocial support of the population. And we, of course, follow by scientifically proven principles and international standards of professional care. Just a couple of words about me. I am a CBT psychologist, and I worked more than 10 years with Pompidou Group Council of Europe and participated in a drug field projects. I am a refugee and fled Ukraine in the beginning of March 2022 with my daughter and her 8 months infant. I'm not going to speak about how horrible it was to spend nights in corridor because under the bombs in Kiev, because we don't have appropriate bomber shells. I'm not going to speak about the scale of disaster and destroyed city, about 8 million of separated families, about murdered, killed, and captured civilians and militaries, about children whose childhood was stolen due to this war, and inability of Ukrainians to build future. I'm not going to talk about the impact of trauma that people experience. This will become very personal for us, and it seems that trauma will continue to generations to come. I'd like to show you 1 minute video We are keeping silent for 1 minute in honor for people who passed away due to this war. Could you please imagine for 1 minute what we are feeling and where we are living right now? Could you please imagine what military feels, whose list of contact is empty because all combats were killed in this dump war, or just came from captivity, lost 25 kilograms, experienced tortures or witnesses tortures of your friend? What could be on the mind of these people? To commit suicide, to drink a lot of alcohol, or to use drugs? Unfortunately, yes. Civilians and militaries, for civilians and militaries, is the simple way in order to mitigate the stress and forget all horrors just for a while. What we do with militaries? How do we start to work? First, we work with trauma. We provide simple Israeli protocols, how to cope with stress, how to find internal resources, basic page, and the breach of life, what to do if you're faced with cognitive, social, emotional, functional discontinuity, in order to renovate this discontinuity. We talked about function of amygdala and precortex in order to show the ways how to switch on the precortex when people are full of their emotions. We use CBT methodology to work with negative thoughts, so we treat them. Why I'm talking about this? Because all these instruments are very effective, not only in improving resilience, but when you are working with people who are suffering from substance use disorders. When we work with trauma, we have the same circles of impact and support. So when person is faced with, when victim faced with trauma, the first responders is the people who are helping them in this accident. In terms of people with SUD, first responders are people who provide first support. So all these circles, family, friends, caregivers, community, and municipality, they should be informed about the specific of drug addiction. What we do, we developed 2 hours interactive webinar, How to Get Addicted, based on training provided by international ITTC in Ukraine and professor from Psychoactive at the University of California San Diego, Igor Kucinuk, and that webinar aiming to dismiss widespread myth, to increase the level of awareness of the problem, to reduce the stigma and discrimination, and to familiarize with harm reduction and treatment methods. And our audience is militaries, families, veterans, psychologists, medical staff, and our partners. And depending on the participants, we change a little bit webinar in order to catch some treating instruments. We start with propedeutica in a simple language about brain development and how neuron connections are changing under influence of psychoactive substances consumption. We sum up that all addiction to psychoactive substances are chronic disease. We emphasize on three definitions that consumption, drug abuse, and addiction can exist independently, or it's a step in order to get illness. Then we talked about harm reduction programs and therapeutic methods, because we have a Soviet Union heritage and some established concept concerning compulsory treatment and coding. Coding means also known as the Dovzhenko method, based on scare. When after scare, patients informed if they start use alcohol, they will be harmed or died. So that we dismiss this non-evidence-based method and provide information about Ukrainian side and use of international approaches of treatment to this audience. Usually I conduct a master class and cover these 6 questions in order to share how to push forward person that has ambivalent thinking. You can see these questions. Honestly, it's worked very well, except military audience, because militaries, they usually keep silence during our webinar, and after they talking about some stories they faced with or asking question. And honestly, it's too complicated to gather it militaries, and we are working with DolaDu in hospitals where they treat it, so that physicians provided medical treatment for militaries, and we provided psychological support and trying to raise the awareness about drug issues and problems. For now, we have conducted, this year we have conducted only 12 webinars and covered 183 participants, and we created a pre and post questionnaire in order to see how the process is going on. So you can see some figures, it's our results. We have 9 questions, because a lot of questions, they confuse, they don't like it. You can see how you consider psychoactive substances addiction a disease. Is it people with SUD fault that they have disorder? People with SUD can stop consumption anytime. Addiction to cannabis is much easier than addiction in opiates. Is the myth that we have here in Ukraine. How fast do psychoactive substances act when smoking? Does addiction to psychoactive substances develop faster among teenagers or adults? And is SUD heritable? Compulsory treatment is an effective tool if person does not realize his problem. And what does the phrase "there are no ex-addicts" mean? Here it's the most resultative answers. You can see how the opinion was changes. It's only a couple of questions, and when we see that the opinion are the stable, we are trying to, to go in depth in our webinar. This is obviously, and compulsory treatment is a really, big problem in our country. So if in previous years we share this information among specialists, now we are working with all audience in order to raise their awareness about this. And what we are doing within the DolaDu, we are thinking to establish a manual of guidelines. It is a disease like the other disease, like hypertension, hypertension or diabetics, and after that, in different even projects, we're trying just to provide information or to have individual consultation or to give to reference to organizations who are really provide a help, because working with military psychologists, they have questions. If the person has such addictions, we should do everything in order to fight him from this service. So thank you for the question as well.
Thank you. My question is for the Nigerian presenter, Dr. Charles. Yeah, that's a good presentation. I was wondering, your intervention, would you think that such an intervention would be very effective in preventing relapse? Because it appears you did a pre and post-test study. What do you think about relapse in this population? Do you think that with assist, maybe people may not relapse after your treatment? Then my second question goes to the Ukraine, but that's a wonderful presentation. Not a question now, but maybe my own suggestion, because there are recent evidences now that people are talking about scalable rehabilitation in military and drug-induced issues, and so many companies are developing apps that could be scalable, because I think we are interested now in providing scalable, affordable treatments. So in one situation, so many people are developing apps that can easily reach those soldiers in the war front. For example, some folks are developing eye movement desensitization and reprocessing in apps, so that it becomes scalable and on time, so that even when people are traumatized in the field, they still undergo some basic psychological first aid through mobile apps. So I was wondering if you could look at that as a form of reaching to the soldiers at trauma, people who are at risk, before the circuitry, because we all know the neurocircuitry following trauma and how it degenerates if it's not attended to. Thank you.
Okay, thank you very much for that question. Will it be sustainable in preventing relapse? The chances are likely that it will be no. But we cannot say categorically because we've not studied that. I say it may likely be no, because brief intervention is for a short period, while motivational interview can provide a long-term change. But we are looking, we've not abandoned the study subjects. So we're still looking at, after 1 year, what will it be like? And maybe when we come up with that result, we can still, like I said, it's still a feasibility study that we are running. And then we could learn from it and speak to the world.
Could you please repeat the question? Sorry.
Well, I don't think it's a question. I'm just trying to reflect on possible ways through which we could also contribute towards reducing or preventing substance use. And I was talking about the recent advances in treatment scalability, that is demonstrating or providing some apps that people could use even in the war front, so that we could find a way to manage trauma as it's happening in the war front. So there are so many apps that people could design to help in immediate intervention, because delayed intervention affects neurocircuitry development that, if not well attended to, will later lead to devastating psychological outcome. So I'm thinking about psychological first aid using scalable instruments.
Yeah, thank you. Yeah, thank you.
Okay, I'll take it up from there for the Ukraine. I'm just wondering also, it's also a comment, not a question, if another way to reach out to persons who, especially soldiers, is maybe to get a bottom-top approach that can be able to help in the management, because some of these supposed people at the top of the military who may not be directly at the war front may not understand. So if there is a way of getting to, some form of intervention measures, I think it will go a long way. But well done for a good job. My question is for the Pakistani study.
Do you want to answer the first question on the
No.
scalability?
I know that some apps is provided in Ukraine here, and I absolutely agree. We are, in the end of the war, not in the middle of the war. Yeah, but what I can say that, first psychological help, and then so that I'm talking about this instrument that we start with trauma, and then we are talking about the disease that people have sorry. Thank you for your information.
Okay, for the Pakistani study, I know that being aware of the fact that we're working with time, we may not have gotten all the information. But I didn't hear you mention how you were able to take care of extraneous variables in your work. Especially if you say you're looking at music therapy, are you saying that it was only music therapy and pharmacotherapy? Was there other form of intervention like sports, psychotherapy? How were you able to exclude that from the study? How were you able to control that? And
Yes.
Can I?
Yes.
And then the second aspect is considering the difficulty of working with people that are psychiatric patients. What were the control measures to be able to help them to be able to stick to the routine of only the music of choice, to be able to say the efficacy of the music therapy is actually a result of X, Y, Z? Thank you.
Yes, basically there are certain barriers in the study, and I don't ignore those barriers. But basically we try our best to provide all the available variables to control. Both the groups given the drugs, pharmacotherapy in the same way, and all the other psychotherapy, CBT, other recreational activities, they all are allowed to participate. The main difference is the music. The one group is only, the other group is not allowed to listen to music. But the experimental group is allowed to, and they also given the choice. They're not forced to listen pop, religious or anything else, but they are just bound to listen music. 45 minutes, 2 sessions, 45 minutes per day. That's the...
I think we have time for at least one more question.
Yeah, actually, I have a question for Dr. Chuck on the ASIS. So I would love to know your reflection on using the ASIS, because I know that the ASIS has been validated in several countries in the world, and that's a good tool. However, I wonder, so from our experience, I wonder if we need to combine the assist with some other indicators because in our experience, so we have screened people and include those with moderate score like four and more into our study, and we measure the substance use with urine drug screen, and there are people who do not use throughout our intervention. That's the first question. So is it really, how useful is it in your opinion? So my second question is getting into the sub-question. So there are like several questions in the assist scale. So because when we test the assist on two different populations, we see that in one, so although the two populations have the same overall score, but then in one population they report that they have less like consequences, but then they have greater motivation to stop using drugs. But in the other population, they report that they experience a lot of consequences, but they have lower motivation to stop. But then, so the score of each question are different. However, the overall score are quite similar. And when we implement the intervention with them, the two populations, they show quite different outcomes. So we haven't done anything to trying to explain the difference. But then I just want to learn from your feasibility study on how you observe the utility of assist in screening. Thank you.
Thank you very much, ma'am. We've only done this study in one community. And before we could speak, we must have a comparative study to say the result we got from community A is different from the result we got from community B. And that is the other side we're looking for future studies now. Is it something particular about this community or about a cultural group or about their educational status or what? Yes, but when we administered the assist, we found out that majority of them were at the severe stage, which made them a cohort with a common problem. And I think part of the comparison we may need to do is people from different communities, from different groups that are at severe stage, what is their response after the intervention? But it is noted, I think is a good point to look further study.
One more question.
Yeah. First of all, I would like to express my thanks to you for all you do. Thank you. Charles, I have a very simple question on you. You mentioned that you have a problem with specialized services and accessibility to the services, and the crucial point of brief intervention is referring people into the specialized services. Are you afraid of motivation of your professionals for doing brief intervention because of hard threshold for accessing to specialized services? If people have no chance to be referred to the services, I'm afraid of motivation of your people, I mean professionals, for doing it because they have no chance to send, or a little chance to send people into the specialized services. By the way, when we made our experiments with pediatrics and nurses for providing brief intervention, the crucial argument or crucial point was, okay, we have a brief intervention, we have a nice training, and it's perfect, but we have no ambulances, we have no outpatient services for kids and adolescents in our country, and we have only 12 specialized services for kids and adolescents. And when we promote, and we are trying to promote brief intervention for pediatrics, we have a problem because we have no specialized services or very little specialized services for this target population. Are we afraid of this motivation, and what's the plan, if you have a plan for it?
Thank you very much. That's a very good question, sir. The Ministry of Health in Nigeria is already looking at that. And there are two approaches that are being looked at. What we have is that the primary health care system has been in existence, but over the years, much attention has not been paid to them. But recently, through the drug acquisition program of the Colombo Plan, they've started adopting it, and they are trying to try the linkage model, whereby the experts, the specialists could organize training for the primary health care staffs who are low cadre staffs on how to administer these assessment tools and provide brief intervention. So that way it will reduce pressure on the experts, on the specialists, and then it will now give room for them to dwell more on the severe cases that may need their attention.
Great, thank you very much. Please join me in giving a last round of applause for our presenters today. I know there's several other questions, and I think our presenters perhaps could stay around for a few minutes if there's others, and I'm sorry that we aren't able to take all the questions. But thank you very much for your participation. I think we're at lunch now, and I wish you a great conference here. Thanks again for your participation.